Hi, and welcome to our next case of mitral stenosis. Now, mitral stenosis is one of the most difficult of all the auscultatory lesions. When it has been studied, and perfect tapes, of mitral stenosis are played to residents in internal medicine residency, not like they're playing it to an orthopedist. But when they are playing perfect tapes of this murmur, 10% of residents can identify it. So, of course, we're going to ask you, who does even less, to identify it as well. And that's the idea that you're going to become better than the residents. You're going to be better than them. You're going to pass them. And that's the idea, that evolution is continuing, and you're going to be better than those people who couldn't identify anything. So we're on our first slide. It is a 25-year-old woman with a history of rheumatic fever. Comes with shortness of breath, cough, hemoptysis, no fever, but she's got a murmur. No fever, but she's got a murmur. 25-year-old woman with a murmur? Well, it could be mitral valve prolapse. 25-year-old woman with a murmur. Does mitral valve prolapse cause hemoptysis? Not in this lifetime. So we have here, let's look at the choices. Now, you might be saying, don't we already know what the diagnosis is? Yeah, but the point is, how do we distinguish it on the other questions to say, why is it not aortic stenosis? Because aortic stenosis in a 75-year-old person, and aortic stenosis presents with syncope, CHF, and angina. Angina, syncope, and CHF. Aortic stenosis presents predominantly with chest pain with a murmur. Aortic regurg presents with shortness of breath. And again, aortic regurg is in people with left ventricular hypertrophy or had myocardial infarctions or ischemic cardiomyopathy or dilated cardiomyopathy. And as the heart dilates, what happens to the leaflets? They must separate. As the heart dilates, what happens to the leaflets? They must separate. What happens to the leaflets? They must separate. Now, mitral regurgitation. Shortness of breath. Shortness of breath. Dilated cardiomyopathy. Ischemia. As the heart infarcts, does it become smaller and tighter or wider and rounder? When you infarct, it has to dilate. No one ever infarcted into a smaller, tighter heart. Cooper's ligaments don't get tighter as you get older. So therefore, as the heart infarcts over time in ischemia, it has to dilate. Now, patent ductus arteriosus, yeah, I like this one. I was just walking down the street, and at the age of 25 years old, I suddenly noticed I got a hole in my heart. Oh, the pieces of my heart are so small they could be put through the eye of a needle. Patent ductus arteriosus, no, showing up suddenly over here, and all of a sudden, oh, by the way, did I tell you I have a continuous machinery murmur? No, it has to be there earlier. So mitral stenosis, why? Because young and female, young person, murmur, hemoptysis. Now, what do we see first in the history to suggest that this is, in fact, mitral stenosis? And the answer is, which of the following is the most likely risk? This is a big deal. What's the most likely risk? Complement deficiency can cause recurrent Neisseria infections. Complement deficiency can cause you to have infection. HIV can cause you to have shortness of breath, but actually not really with the murmur. Does HIV predispose to endocarditis? No. Injection drug use gives you HIV and endocarditis. But HIV itself does not cause cardiac lesions. No. So HIV can cause shortness of breath, but not the cardiac lesions. The answer is, in this case, an immigrant. This is a beautiful question because it really is working backwards, a real clinical reasoning question. You have to make the connection, although it's not stated, that this is mitral stenosis, that there's rheumatic fever, and make the connection to who gets rheumatic fever. Rheumatic fever is an economic disease. If you show me a country with a per capita income above $12,000 a year, I will show you a country with no mitral stenosis. If you show me a country that has a per capita income above $12,000 a year, I'll show you a country that has no rheumatic fever, no tuberculosis, very little syphilis, no cholera, no neurocysticercosis. You see, these are economic diseases. What we know about health aid is that health aid to foreign countries hasn't worked out so well. Me speak with forked tongue because I say that and then I do it. However, what we know is that as a natural consequence of expanding economies, the first thing you do when you got your money is people actually don't get a Lexus and a Louis Vuitton bag. They spend $1 on antibiotics for the kid's sore throat. And as a matter of fact, in developing countries, penicillin, which can be made cheap locally, in reality costs about a penny a pill. So therefore, when you have these people who have a naturally growing economy, it eradicates mitral stenosis. I know what you're thinking, right? You don't know whether you should spend your life devoted in the laboratory to the cure of rheumatic fever or to free checking. I understand that. I understand that. If you get everybody free credit, you can virtually eliminate mitral stenosis in the entire world. Immigrants, rheumatic fever. There are about 300 cases of acute rheumatic fever a year in the entire United States. Very, very tiny. Let's look at the next question. Now remember that we're purposely keeping the question, the root case on top, so that you don't go, which case are we talking about? We're always talking about the same case, unless stated otherwise. So the same lady comes in and says, which of the following will prompt her to seek medical attention? What makes her come in? Why this happened now? She had rheumatic fever. You have rheumatic fever when you're 8 and 9 and 10, and it takes 10 to 15 years later to get the carditis. Before those valves go, scrunchy, scrunchy, scrunchy. It's like scleroderma of your heart. Now, why is it that it takes 15 years? Because it takes a long time to fibrose. What makes them come in at the end? Well, anything that suddenly increases plasma volume. Anything that suddenly increases plasma volume makes you come in. Anything that increases plasma volume. Now, that could be a person who decides that they want to go have the all Gatorade diet. It can't be alcohol, because alcohol is a diuretic. Alcohol inhibits antidiuretic hormone. Hence the phrase, you don't buy the beer, you only rent it. So therefore, what gives the person out of all these? It is true that infections cause an increase in cardiac output, an increase in demand. But severe infections, severe, like noticeable infections, like sepsis infections, not like a cystitis. You see, you don't get an increased cardiac output for cystitis. You don't get an increased cardiac output for cellulitis. You don't get an increased cardiac output for these minor infections, for bronchitis. We had sepsis, yeah. Major, serious infection. And you have vasodilation, septic shock, but not just little infections. And besides that, nobody has the kind of infection that causes the acute pulmonary edema and shortness of breath of MS without you noticing it. Next, ischemia. That can make you short of breath, but it doesn't unmask mitral stenosis too much. If your valve ruptured, well, it actually kind of relieve mitral stenosis in a way, kind of relieve the obstruction. So ruptured valves, like infection and infarction, and infarction and infection, and infection and infarction and infarction and infection. Ruptured valves can cause acute pulmonary edema. However, they don't make the mitral stenosis worse. And weight loss actually probably decrease the problems with it because it decreases your cardiac output. So pregnancy is the answer. And I'm going to tell you, ready? For mitral stenosis, you're going to look for an immigrant female with more shortness of breath during pregnancy. Because when you become pregnant, what happens is you get a 50% increase in plasma volume. Because when you are pregnant, you are so ripe. You are so full. You are so juicy. Why, you're like a big melon. You're so ready to pop. You get a 50% increase in plasma volume, but the mitral valve stays stenotic. Where's the blood going to go? It's going to back up in the lung, baby. It's going to back up in the lung. Okay? So when you get pregnant, the belly gets big and plasma volume goes up. By the way, that's why every pregnant woman automatically gets anemic. You can't not get anemic if you're pregnant. One, you can't absorb enough iron. You need 5-6 milligrams a day. You top out at 3 or 4. Number two, the plasma volume goes up. Ta-da! Pregnant woman. Next one. Now, 25-year-old woman, past medical history of rheumatic fever, comes in for increasing shortness of breath on exertion. Which of the following murmurs is most likely to be found? Now we're going to listen to 5 murmurs. And again, if you... Look, man, if you get even one of these auscultation questions right, you're doing terrific. I'm telling you, that has been studied to look at 4th-year students, residents, cardiology fellows, and attending physicians. Do you know that the only person who does significantly better is the cardiology fellow? Did you know that a 4th-year medical student and the average attending physician in internal medicine have the same ability to detect mitral stenosis murmurs? You know that? I bet you didn't. I bet you were too busy being told by your attendings that they were better than you, right? How many of them ever told you that you are the best year ever to come out of medical school? You are. How many of them ever told you that you are the most qualified, most expert, most knowledgeable, the very peak of the generation? Yeah, you are. USMLE scores 20 points higher on average than it was 15 years ago. IQ is higher, 3 points a decade. And you are just as good as your attendings at identifying mitral stenosis here. So let's start to play these murmurs. We're going to play them one by one. Okay? Start with murmur 1. Now you keep playing it as long as you want until you're sure, and then I'll tell you what each one is after we play each one, okay? So murmur 1. Now, murmur 1 is a diastolic decrescendo murmur. Lub, 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 and it's heard at the lower left sternal border. Lub, lub. I will now act out all the murmurs. Wait till we do vowel sounds later. Oh, and this is lactose intolerance. Now, their next murmur. So the first murmur, diastolic decrescendo murmur, that's aortic regurgitation. Next murmur, murmur 2. Keep playing it. Is that mitral stenosis? Next, the second murmur is S2, S1, dub, blub, dub, lub, dub, lub, dub. Clear S1 and S2. I hope it's clear to you. You must also take for granted, by the way, that if I say what you're supposed to hear and you don't hear it, it's because it's difficult sometimes. It's difficult. You see, the more you study the murmurs, the more distinct they'll be. The second murmur is lub, diamond-shaped, crescendo, decrescendo, dub. And if you don't hear it, the more you hear it, the more you'll have a distinction. Okay, it's like the Little Prince, Le Petit Prince, right? Yesterday, my rose was like any other rose on the bush. But today, my rose has become special to me in all the world. So it's like, yesterday, this murmur was another murmur, like any other murmur in the loch. But now, this murmur has become aortic stenosis to me in all the world, murmur 2. Now, murmur 3 should be one sound. Listen. Keep listening. Pansystolic or holosystolic murmur. Pansystolic or holosystolic murmur at the apex going to the axilla. Pansystolic holosystolic murmur at the apex going to the axilla. Pansystolic holosystolic murmur at the apex going to the axilla. That is mitral regurgitation. That's mitral regurg. Next one, number 4. Number 4. Listen. Listen. Lub, click, dub. 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 Hard for you to understand. Hard to understand, okay? I will tell you that murmur number 4, which is to say choice D, is one of only 2 left-sided murmurs that the more blood you put in the heart, the better the murmur gets. More blood, this one improves, becomes softer. Number 4 is one of only 2 left-sided murmurs that improve with more blood in the heart. It's mitral valve prolapse. Now, this is an important one for this patient because as a 25-year-old woman, mitral valve prolapse is entirely possible, but the presentation is totally wrong. People with mitral valve prolapse don't present with shortness of breath and hemoptysis and cough. People with mitral valve prolapse, mitral valve prolapse present with atypical chest pain, palpitations, panic attack. They present with change, pain, palpitations, panic, pain, palpitations, panic. And this person doesn't have any of those things. So murmur 4 of mitral valve prolapse. Murmur 5, choice E. Murmur 5, choice E. That's a pericardial friction rub. That's a pericardial friction rub. Very difficult pericardial friction rub. Now, choice F. I get the feeling this must be it. How do you know? Because it wasn't the other 5. So mitral valve prolapse, mitral stenosis, the last murmur. Mitral stenosis, the last. Last murmur. Listen. Oh. In the room, the women come and go, talking as Michelangelo, making decisions and revisions, which a minute will reverse. For I have measured out my life in coffee spoons, and I have heard the mermaids singing, but I know they do not sing for me. What do you hear here? Oh, that's mitral stenosis. Yes. Lub, dub, extra sound, diastolic decrescendo murmur. Lub, dub, extra sound, diastolic rumble. Lub, dub, diastolic sound, diastolic rumble. Lub, dub, diastolic sound, diastolic rumble. Lub, dub, diastolic sound, diastolic rumble. Mitral stenosis, choice F. Now, you go back as much as you have to hear those murmurs till you get it right. You go back as much time as you want till you have had enough, and you'll be set on everything. Now, here's the answer. And our next one, 25-year-old woman, past medical history of rheumatic fever, comes in, physical examination, she's got a murmur, which will increase the intensity of this murmur. Now, this is a very important question for us because even though I know that 99% of you have never done amyl nitrate alterations on a murmur, that maneuver ever, not in a murmur, you're still expected to know physiologically what's it supposed to show. What's it supposed to show? It's like a theological discussion. I know you have never seen it, but you're supposed to know what it sounds like when you do hear it. Okay. Song of Bernadette. Our Lady of Lourdes, Song of Bernadette. For those who believe, no explanation is necessary. For those who do not believe, no explanation is possible. It's the same with amyl nitrate, hand grip, and other auscultatory maneuvers. It's a faith-based initiative. Hey, what does amyl nitrate do to the heart? Amyl nitrate is an arterial vasodilator. Amyl nitrate is the anti-ACE inhibitor. Excuse me, it's like an ACE inhibitor. Amyl nitrate is like an ACE inhibitor. It basically decreases afterload. That's what amyl nitrate does. It's an arterial dilator, decreases afterload. Hand grip. Ready? Hand grip. What's that supposed to do for you? Besides show off Dr. Fisher's triceps, y'all. Hand grip does not increase venous return. It's not like upper extremity squatting. Hand grip clamps down on the arteries of the arm, compresses the arteries of the arm, and decreases cardiac output, because hand grip, by compressing the arteries of the arm, prevents blood from getting out of the heart. Hand grip compresses the artery of the arm and decreases the ability of blood to leave the heart. Amyl nitrate is an arteriolar dilator. Hand grip constricts or presses down on the arteries. Amyl decreases afterload. Hand grip increases afterload. This is a big deal because it means that if your murmur would get better with an ACE inhibitor, like regurgitant lesions, AR, MR, they get better with afterload reduction. It means that amyl nitrate will decrease those murmurs because amyl nitrate is like an ACE inhibitor. And it means that hand grip, which increases afterload, if your murmur, aortic regurg, and mitral regurg gets better with an ACE inhibitor, it means those will get worse with hand grip. Those will get worse with hand grip. AR and MR, aortic regurg, mitral regurg, are treated with afterload reduction, which help the blood get out of the heart. That means hand grip will make them worse. Okay. Leg raising. When you lift your legs up in the air, it pours blood into the heart. When you lift your legs up in the air, it pours blood into the heart. When you lift up your legs in the air, it pours blood into the heart. Increases venous return. More blood in the heart. Standing. You're going from a squatting position to standing up. It opens the capacitance vessels of the legs. You're going from the squatting position to standing up. It opens the capacitance vessels of the legs. Legs and thighs have an awful lot of volume. Your thighs have so much volume. Oh yes, it's true. So you actually, when you go from a squatting position to standing, can open up the capacitance vessels of the legs and can pool an enormous amount of blood there. So standing and Valsalva decrease venous return to the heart. Standing, by opening the capacitance, going from a squatting position to standing up, opens the leg veins and blood pools there, less venous return to the heart. Valsalva, you ready? Exhalation against a closed glottis. Exhalation against a closed glottis. Valsalva increases intrathoracic pressure and will decrease venous return to the heart. Valsalva increases intrathoracic pressure and decreases venous return to the heart. Valsalva. All right, let's review. Amyl nitrate decreases afterload. Hand grip increases afterload. Leg raise increases venous return to the heart. Standing in Valsalva will decrease venous return to the heart. Which of these will increase the intensity of the murmur? And the answer is the leg raising. When you lift the legs up in the air and you pour blood into the heart, there's more blood in the heart to get through the same stenotic valve. Worsens. When you get pregnant and you increase plasma volume, you have more blood, more volume to get through the same stenotic valve. It gets worse. Leg raising pregnancy, salt, too much salt, they all make mitral stenosis worse. There is no meaningful effect on mitral stenosis of afterload increases or decrease, because afterload increase or decrease have to do with ventricular emptying. Afterload increase or decrease have to do with ventricular emptying. And here we're looking at ventricular filling. So there's no effect. Next one. 25-year-old woman, past medical history. Which of the following is the mechanism for the hemoptysis? Well, when the blood can't get out of the left atrium, where's it back up to? The lungs. Where's it back up to? Pulmonary artery, pulmonary vein, pulmonary veins, pulmonary veins, pulmonary artery. So when the blood backs up into the lungs, the pulmonary veins get swollen and big and engorged. That's where you get a high wedge pressure. When the blood backs up in the left atrium, the blood backs up and you get swollen, engorged pulmonary veins, which burst and you get hemoptysis. So it's a type of pulmonary hypertension. It's a type of pulmonary hypertension. Next one. 25-year-old woman who's coming in. And she's got this rheumatic fever and cough and shortness of breath. What's most likely to be found in this patient? Look at these physical findings. What's most likely of these physical findings? Cyanosis just means blue. Well, I don't know. When I'm feeling blue, all I have to do is intubate you. Then I'm not so blue. When you ventilate me and you oxygenate me, well, when I'm feeling blue, all I have to do is ventilate you. But that's not particular to mitral stenosis. Actual cyanosis, turning blue? Not really. It's not cyanotic heart disease. You could say from one point of view, any cause of shortness of breath that got bad enough can make you blue, but it's not cyanotic heart disease. Cyanotic heart disease, that term means you have a shunt that's putting a lot of unoxygenated blood into systemic circulation. That's like septal defects or PDAs. Dysphagia. Dysphagia occurs because the most posterior structure in the heart is the left atrium. And if you're in the esophagus, and the left atrium hypertrophies. Hey, excuse me, back up. Hey, stop squeezing me, your left atrium. Hello? How do you expect me to swallow when you got this left atrium squeezing my head? Left atrium, you're squeezing my head. And that's what happens while you get dysphagia. Because as the left atrium hypertrophies backwards, it squishes the esophagus. If the left atrium hypertrophies backwards, it squishes the esophagus. Now, Kussmaul's sign. What happens to your neck veins when you inhale? Normally, neck veins. Do they go up or down? Do they increase or do they decrease? What happens to your neck veins when you inhale? Do they increase or do they decrease? And the answer is, normally, when you inhale, your neck veins should decrease in intensity. When you inhale, your neck veins should decrease. Kussmaul's sign is an increase in jugular venous pressure on inhalation. Now remember, not Kussmaul's breathing. Kussmaul's breathing is just rapid, deep breathing. Man, Kussmaul, he was smart, man. Guy got his name attached to deep breathing. Kussmaul's breathing is what you see with DKA or sepsis, big hyperventilation. Kussmaul's breathing is what you see with DKA or sepsis, hyperventilation, deep, rapid breathing to compensate for the metabolic acidosis. Kussmaul's sign. Kussmaul's sign. Okay. Kussmaul's sign is typically seen with, Kussmaul's sign is an increase in jugular venous pressure on inhalation. Look, this is how these questions go. This is very step 2-like. Which of the following physical findings most likely to be found in this patient? That's why we have physical findings flashcards. Why? Because it says, what is this physical finding and when do you find it? What is this physical finding? When is it the answer? Kussmaul's sign, increase in jugular venous pressure on inhalation. When is it the answer? Constrictive pericarditis. Constrictive pericarditis. Pulsus paradoxus. Ready? A pulsus paradoxus is a decrease in blood pressure. Decrease in blood pressure more than 10 millimeters of mercury on inhalation. Everybody's blood pressure, when you inhale, does it go up or does it go down? When you inhale, does your blood pressure go up or does your blood pressure go down? And the answer is your blood pressure should go down. Because as the right side of the heart gets bigger, the left side of the heart gets smaller. Because if you're in a confined, contained box, as the right side of the heart gets bigger, it squishes the left side. So it is natural on inhalation for your blood pressure to decrease a little bit. But it should be 3, 5, 7 millimeters of mercury, not 12 and 14 and 20. A pulsus paradoxus is a greater than 10 millimeter of mercury, 10-point drop in blood pressure on inhalation. It's a greater than 10-point drop in blood pressure on inhalation. Greater than 10-point drop in blood pressure on inhalation. Okay? So, pulsus paradoxus is you breathe in, the blood pressure drops abnormally. It drops 10, 15, 20 points. And it drops below the point at which you can feel the pulse. Hey, no pulse. Wow. Pulse came back. Wow. You inhale. No pulse. Hey, the pulse came back. How much blood pressure do you need to feel a radial pulse? How much blood pressure? 120? 110? 105? The answer is you need a systolic of about 90 to feel a radial pulse. You need a systolic of about 90 to feel a radial pulse. So if you're normally at a blood pressure of 100 to 110, and now your blood pressure drops 15, 20, 25 points when you inhale, it can drop below the systolic of 90 that you need to feel a radial pulse. And then it comes back. Wow. You lost your pulse when you breathed in, but you're still alive. Wow. How paradoxical. You lost your pulse, but you're still alive. Pulsus paradoxus is seen with patients who have cardiac tamponade. Now the last two, an S3 gallop we talked about before, that's fluid overload, major volume overload, S3 gallop. That's rapid ventricular filling. Well, you can't have rapid ventricular filling when you got a stenotic mitral valve. That's out. That's out. S4 is atrial systole against a stiff and non-compliant left ventricle. S4 is atrial systole against a stiff and non-compliant left ventricle. Well, you can't get a bang of blood with atrial systole when, in fact, there's a stenotic valve in the way. You can have all the atrial systole you want. It's bang on the valve. You get dysphagia because the left atrium is the most posterior structure in the heart. It enlarges backwards and squishes the esophagus. So that's what you see. Ooh, let's see here. Rheumatic fever comes on in. Person's got no fever, but they got a murmur. And let's look at Swan-Ganz readings. Now, ready? I didn't say that I would do a Swan-Ganz. I didn't say I was going to do it. I didn't say I was going to do that. But it doesn't mean I'm not expected to know how to do it. That thing I talked about, I never said I was going to do it. Swan-Ganz? I never said I was going to do it. But it doesn't mean I don't know how. Just because you don't do something doesn't mean you're not expected to know how and what it shows. Swan-Ganz. Boom. Right in there. I'm not going to do it routinely. What's it expected to show? Well, when you have mitral stenosis, what happens to your cardiac output? Does it go up or down? Must go down. I mean, if it didn't go down, why would we be having this discussion? We wouldn't be talking about it. It wouldn't be congestive failure. It wouldn't be shortness of breath. It wouldn't be RALS. It wouldn't be shortness of breath. We wouldn't be having this chat. You wouldn't be getting, if you had normal cardiac output, you wouldn't be getting these problems. You have decreased cardiac output. So that automatically means B and C are out. Next, what does the wedge pressure show? Wedge pressure measures left atrial pressure. Wedge pressure measures left atrial pressure. Does the wedge go up or down with mitral stenosis? The blood can't go forward, so it goes backwards. And that backward flow of blood out of the left atrium, the backward flow of blood out of the left atrium is the wedge. Now, you can get the answer to this question just by looking at wedge and cardiac output. Choice A shows that there's decreased cardiac output. The increased wedge because there's back pressure from the left atrium. The reason that SVR stands for systemic vascular resistance. It's how constricted the blood vessels are. The reason that the blood vessels are very constricted in a person who's got mitral stenosis is because the vasculature is empty. And since the vasculature is empty, the body compensates for that by constricting those blood vessels. The vasculature is empty, so the body compensates for that by constricting the blood vessels. So the resistance should go up. And the pulmonary artery pressure is up because, again, that's back pressure. Choice is A. Swan-Ganz catheters. I didn't say to do them. But what are they supposed to show? Two different questions. Our next question says, do you understand the physiology of what makes an opening snap? Snap. When the left atrial pressure is greater than the left ventricular pressure, the mitral valve will open. When the left atrial pressure exceeds the left ventricular pressure, the mitral valve will open. Now, when mitral stenosis gets worse, this question. When mitral stenosis gets worse, what happens to the left atrial pressure? Does the left atrial pressure go up or down as the mitral stenosis gets worse? And the answer is that the left atrial pressure should go up as the mitral stenosis gets worse. The left atrial pressure should go up as the mitral stenosis gets worse. So, that means, when will opening snap happen? If the left atrial pressure is going up, will the opening snap occur earlier or later? The opening snap happens when the left atrial pressure exceeds left ventricular pressure. So, will the opening snap happen earlier or later? And the answer is will happen earlier. Why? Because the very definition of mitral stenosis is the S2 to opening snap distance. The worse the disease, the earlier the opening snap occurs. Now, I know what you're thinking. You're probably thinking like I used to do, like mitral stenosis is like pushing a door open. Like, oh man, this mitral stenosis is getting worse. No, it's not like that. It's not like pushing open a creaky door. The mitral stenosis is getting worse, man, and late. No, it's a pressure thing. It's a pressure thing. As the mitral stenosis gets worse, the pressure goes up, and the pressure pops open the valve. Softening of S1? No, it's quite the opposite. You get a louder S1. Softening of S1 happens in things like mitral regurg. You get a louder S1. Now, normally the mitral valve closes by itself, a little flop. Lub, dub. Lub, dub. Now, as mitral stenosis gets worse, does the valve close easier or harder? Does the valve close easier or does the valve close harder? The opening snap happens earlier, but as the disease, does the opening snap happens earlier, but the S1 is the closure of the mitral valve. Well, what happens in mitral stenosis is that instead of the normal, watch this now, it's important, instead of the normal, lub, dub, lub, dub. Now you get this creaky mitral valve. And the mitral valve is halfway open by the time the ventricle contracts. So instead of the normal lub, dub, Now the mitral valve is half open. And the ventricle contracts. Instead of the normal dub, dub, the mitral valve is half open. The mitral valve is half open. Ventricular systole occurs and bang. The mitral valve is half open. Bang. And that's why you get a loud opening snap, because it's premature closure of that mitral valve because the damn thing's not going closed by itself. So the opening snap is earlier with mitral stenosis as it gets worse, and the S1 is louder. Louder. It's like slamming a door. It's like slamming a door.